Namaste. Until now, we discussed the systems approach to errors, human factors engineering, and we discussed how we can be part of effective teams. We also learned some techniques of effective communication while in a team, such as the IS bar, S bar, I pass the baton mnemonic for handoffs, callouts, checkbacks or readbacks, and the CUS and DESC scripts. I hope you have started practicing these evidence based methods of communication in your workplace. In this module, we are talking about learning from errors to prevent future harm. All errors are opportunities we get to review our system and find out why things went wrong. We need to know what are the various types of errors and how they occur. And remember, learning from others' errors is also very important to enhance our own patient safety outcomes. The objective of this module is to learn the nature of error and how we as healthcare providers can learn from errors to improve patient safety. So we have in an earlier module discussed a few definitions of the term error. Simply stated, errors are doing the wrong thing when actually meaning to do the right thing. James Reason's definition is that errors are planned sequences of mental or physical activities that fail to achieve their intended outcomes. And these failures cannot be attributed to chance factors. Remember, violation is a deliberate deviation from standard protocols and procedures. For example, not performing hand hygiene between examining patients. We have earlier seen the three types of violations: routine violations, which are minor and more tolerated ones, optimizing violations due to recklessness of staff, and necessary violations, usually due to organizational failures such as lack of adequate supplies. The interesting thing about errors is that they are not totally and completely linked to poor outcomes. What I mean is that errors occur in large numbers daily, but not all errors lead to harm. Human bodies can tolerate quite a bit before harm actually occurs. Now, let's take the example of a patient inadvertently receiving a dose of paracetamol that was intended for the patient on the next bed. This is an error, but it most likely won't result in some kind of a harm to the patient who received that paracetamol. Sometimes, even when many things go wrong, patients might not experience any harm. And therefore, the definitions of errors do not include outcomes. So, it is not about whether someone is harmed or not, but about the fact that an error did occur. Most often, errors are recognized before the harm occurs. Now, in the module on human factors engineering, we discussed how humans are prone to making errors. There are several reasons why we make errors. Sometimes it is due to individual factors such as being tired, fatigued, or being inexperienced. Other times it is due to team related factors such as poor communication or overburdened team members, or task related factors. Maybe the task that we performed is too complex or too repetitive, leading to inattention. Whatever the case, we are not infallible. We will make mistakes regardless of how experienced, smart, or driven we are. Now, I want you to pause this video and head over to the discussion forum where you must think about and discuss any one silly mistake you may have recently made while you were not working or studying. Also, I want you to discuss why you think the silly mistake happened. Now, although it may sound to you that errors in medicine or medical healthcare errors are unique to the field of healthcare, the truth is that all kinds of errors that we make are more or less the same across various professions. A plastics factory worker may forget to turn on a specific machine, resulting in a batch of defective products, just as a doctor may forget to turn on the oxygen valve while ventilating a patient. The difference between errors in healthcare and those elsewhere is that the healthcare errors can have direct consequences for the patient, who is already a vulnerable and sick individual. Now, errors can broadly be classified as skill-based errors or mistakes. Skill-based errors are when actions we take don't go as intended. These may further be slips of action. For example, during a Ryle's tube insertion, the tube goes into a bronchus and the nurse initiates feeding. The other skill-based error is lapse of memory. During a copper T insertion, the intern forgets an important step, and this results in harm to the patient. The second broad category of errors are mistakes. A mistake is when we choose the wrong action. It is a failure in the planning stage. A mistake may be rule based. When we choose the wrong rule, for example, when treating a patient for a suspected diagnosis of gastric ulcer, when actually she has angina. The physician may have started antacids, which would be appropriate for the treatment of an ulcer, but it was inappropriate for this particular patient because she had a cardiac problem. So the physician applied the wrong rule in this case. Knowledge-based mistakes are made when an inexperienced or not enough knowledge is there. For example, an intern who prescribes a higher antibiotic when it was not appropriate because he doesn't have much knowledge about using antibiotics correctly. So here are some more examples of skill-based errors and mistakes. A surgeon chooses the wrong type of suture for eyelid surgery in a hurry. This is a skill-based error and is specifically an attentional slip of action. A resident doctor, confused regarding the doses of a drug, prescribes an incorrect dose to an adult patient. This is a memory lapse. A doctor who fails to order a urine pregnancy test for a patient who missed 2 menstrual periods may be an example of a rule-based mistake. The doctor did not apply the correct rule in the situation. And a physician who has never seen Creutzfeldt-Jakob disease, a rare prion disease, may fail to diagnose it in a patient. That becomes a knowledge-based mistake. We did discuss earlier the situations that are associated with increased risks of error, and these include lack of experience, especially early in our careers when we are more likely to make errors than later. Working under time pressures with deadlines, large number of responsibilities, inadequate checking. When we habitually check our actions, the likelihood of errors reduce. An example of this is routinely checking the medications that your patient has purchased. Poor procedures, lack of standardized ways of working, lack of supervision, especially with junior or less experienced staff, inadequate or poorly documented information. If handwriting is not clear and legible or information is incompletely recorded. Lack of help seeking is another problem that plagues the healthcare industry. We often feel anxious about coming across as ignorant or stupid and fail to ask for help and assistance when actually it is the right thing to do. The individual factors that predispose to errors have been seen earlier and include several factors such as cultural and linguistic difficulties also. We have been taught for generations that good professionals know everything, and so referring to books or guidelines, especially in front of patients themselves, is considered an indication of being inadequate. This thought process needs to undergo change, as relying on memory is not only unnecessary in clinical practice, but it can also lead to errors. Remember to halt when you're hungry, angry, late, or tired. We have discussed this in a previous module. Seek help from a colleague or take a break and inform your supervisor. We also discussed the I am safe checklist. If you're ill, on over the counter or other medications, are stressed, under the influence of alcohol, fatigued, tired, or are emotionally disturbed, you may not be safe to work and you must take appropriate actions. Now, after looking at errors, the classification of errors with several examples, and what predisposes us to errors, we now come to study what should happen when errors occur. The way in which we can learn from errors is through the process of incident reporting and monitoring. This involves collecting and analyzing relevant information about any event that could have or actually did harm someone. It is a systematic method of obtaining all the information we need in order to understand and learn from errors. It is a fundamental component of any high reliability organization or HRO that we learned about previously. Incident reporting systems help identify recurring problem areas which are known as error traps. An example of an error trap is a lack of proper adverse drug reaction or ADR documentation protocol in a hospital. Poor documentation system is likely to be a source of recurring errors. Incident reporting and monitoring allows the hospital authority to improve the processes which are potential error traps. Another concept is the hindsight bias, and it is something we all engage in at times. After a difficult exam, a student may say, I knew it was going to be a difficult paper. After a breakup, someone might think, I knew we would break up, we were just not made for each other. In healthcare, an example may be after a patient falls in the ICU nurse might think, I knew this would happen. The bed railings were loose. In reality, many things go wrong before an incident occurs. But when we think about it after the incident, we often only see the sharp end of care as having gone wrong. We only see the leading edge. And this is often the case in person approach to errors. An important construct of any organization is its culture. What is a culture? In routine situations, we might say culture is the general way of living and conducting ourselves, the way we dress, the way we talk, the food we eat, what and how we celebrate festivals, and so on. And these are common between a large group of people with whom we share our culture. Similarly, in an organization, the shared values and beliefs that interact with the structure and control the systems within the organization to produce behavioral norms is the organizational culture. For example, a hospital may routinely celebrate employees' work anniversaries in a particular manner, or employees involved in errors may be routinely issued memos. These are examples of an organization's culture, the way they do things there. Now, incident reporting is heavily dependent upon the organizational culture. If there is a person approach to errors being followed in an organization, then the number of incidents reported will be less than the reality. And so, such an organization would fail to learn from its failures and improve outcomes. But when organizational culture allows communication and disclosure of errors, then incident monitoring and learning from them becomes routinely possible. So it is correct to say that even if you can't change the world, you can look out for ways to improve the system you are a part of, and you can contribute to a positive workplace culture. Now, some ways of ensuring successful incident reporting and monitoring include allowing and encouraging anonymous reporting through various discrete portals or mailboxes or even small little wooden boxes placed in the key areas of the hospital. We sometimes hear of the term whistleblowers when it comes to these things, but it is often met with resistance. Nobody likes to be reported. Timely to and fro feedback and openly acknowledging successes from incident reporting systems are valuable. Even near misses must be reported. Even though no harm occurs to the patient in a near miss incident, it is a valuable opportunity to learn lessons so that the next time around it doesn't become a sentinel event. So you can consider these as free lessons as the industry learns from these events without any harm done to a patient. Now, whenever a safety incident occurs, organizations are encouraged to perform what is called the root cause analysis (RCA). At the beginning of the course, we saw Shamla's story, and we saw that she developed a hospital-acquired infection in the surgical site, which increased her hospital stay and cost of treatment. Now, if the hospital administrator wanted to find out how and why this occurred, he might perform a root cause analysis. There are several methods of performing root cause analysis. Let's try and understand the process a little more. Now, the root cause analysis is a systematic, rigorous, and confidential approach to incident reporting and monitoring. The RCA evaluates and analyzes serious adverse events and develops systems improvements to prevent their reoccurrence. No matter what method we use for the RCA, the common questions asked and answered are: what happened? Who were involved? When did it happen? Where did it happen? How severe was the potential or actual harm? What is the likelihood of recurrence? And what are the consequences? So the typical steps involved in an RCA start with first identifying and characterizing the problem. Identifying the level of harm. Levels of harm may be level 1 harm when there is no harm or is a near miss event. Level 2 is severe harm or death. And level 3 is severe harm or death, but it is of public interest. For example, a leak of a virus from a high security lab. Then creating a multidisciplinary team, which should include the subject experts, non-subject experts, lay persons, and administrators. The RCA team then begins conducting confidential interviews with the stakeholders and document reviews to gather relevant information regarding the incident, and they try to map it. They try to identify care and service delivery problems, which include acts of omission as well as commission. The team then analyzes the data that is collected and identifies factors that may have contributed to the incident as well as the root causes. Based upon their findings, the team makes recommendations and solutions which are then implemented, and finally, a root cause analysis report is generated. Root cause analysis often uses the 5 whys technique of getting to the root of an incident. In an earlier module, I had introduced the 5 whys technique of getting to the bottom of a problem. It is simply sequentially asking why until we reach the end point of the inquiry. The RCA focuses on preventing errors in and incidents in the future, not on blaming or punishing someone. It tries to identify the system level problems that can be addressed. RCA examines factors such as communication, training, scheduling or rostering problems leading to fatigue, environmental difficulties, organizational factors, and other various barriers to safe healthcare. Now, there are some strategies you can use to ensure you contribute to safer healthcare. Know yourself well, look after yourself, eat well and sleep well, know your environment and your task well. Spend some time familiarizing yourself with your work profile and your place of work before actually starting. Prepare and plan for when things go wrong. Be preoccupied with failure like high reliability organizations are. Ensure you create a habit of checking routinely. Did the patient purchase the correct medications as you had prescribed? Did you write the name of the patient correctly in documents? And so on. And ask for help, for information, and for guidance on time. Hope for the best and prepare for the worst. Assume that errors will occur. Identify the situations and circumstances that are most likely to breed error. Devise emergency and contingency plans to cope with problems, distractions, and interruptions. So have your plan B, C in place. And always mentally rehearse complex procedures and steps. To summarize, healthcare is complex and errors will occur no matter how expert or careful we are. It is better to focus on learning from errors for productiveness at an organizational level as well as individual level. For this purpose, we must habitually use the root cause analysis models. Thank you.